Paliwal sir, he's an MD anesthesiologist. He's an associate professor at Dr. PDMMC Amravati, faculty at various state and national conferences, various publications on segmental spinal and DEX. These two things are pioneer things of Dr. Naresh Paliwal sir. You can also consider it as trademark things. Uh, he uses on dexmedetomidine and ketamine combination in pediatric patients. And best paper award at Isakon Mahara at Nagpur. So very much welcome, sir. You came on our platform as a speaker. Very, very much thank you, sir. Please continue, sir. Yours.
Hello, am I audible?
Yes, sir. Yes, sir.
Yes. Just let me see if I can share my screen.
Yes, sir. You can continue now.
There is some error. Sharing your entire screen or browser window can cause an infinity mirror. Should ignore this, no?
Share your screen, sir.
I'll just stop sharing and then share again.
Yeah.
Your entire screen or only presentation? I think only presentation.
Entire screen, sir. Entire screen. You just start your presentation and you see on your mobile also. No issues on that.
Are you able to see my screen?
Yes, sir.
I'm not able to see anyone now. I'm seeing
Yes,
only
yes,
my
sir.
screen.
This is the issue with GMT. You cannot see
Okay.
anybody. If you
Okay,
want
you
to
are
see,
able to see my.
yes,
You are
yes,
able
sir.
to see my entire screen.
Yes, sir. Yes, sir. If you want to see, you can join with on mobile also.
Okay, no issues. I just wanted to confirm whether you are able to see
Yes, sir.
or not. At the outset, let me thank ISN Nanded for inviting me again. This is actually my second or third time when I am presenting to Nanded. First time I presented at Sakon Nanded this topic. I'm very much thankful to ISN Nanded for giving me this opportunity. Now coming to my presentation about segmental spinal. Something about the history and the current status. It was in 1909, Thomas Janesco proposed the term general spinal anesthesia for surgeries of head, neck, and thorax by giving spinal at T1, T2 levels. But it was in 2006 when the new era began, when Evan Zundert gave spinal at T10 for laparoscopic cholecystectomy in a patient with severe COPD. Since then, there have been many studies. Actually, I am using this technique and presenting this since last 10-12 years. And recently, we conducted a workshop at Navsari, a live workshop, first time. And next month, at 15th of May, we will be having another workshop at our own institute, Dr. PDMMC Amravati, on the same subject. So it has become the most trending regional anesthesia technique recently. Now, what is segmental spinal? The term is often used synonymously with thoracic spinal, but even the low doses of the drugs used at high lumbar levels can produce a segmental effect with sacral sparing. So the ideal definition should be blocking of the required dermatomes, essential for the proposed surgical procedure with very low volume of local anesthetic drug by giving spinal near the targeted nerve roots. This often necessitates dural puncture at high lumbar or thoracic levels. Lower the volume or the dose of the drug used, more likely to produce a true segmental block. There are some factors which make segmental spinal feasible. In thoracic segments, the spinal cord is positioned anteriorly, leaving a significant space between the posterior dura and the spinal cord. The thoracic nerve roots are very slight and thin, so they are efficiently blocked with a very low dose of drugs used. Amount of CSF at thoracic levels is comparatively less, and there is no difference in the onset time for isobaric and hyperbaric drugs at thoracic levels. While the isobaric drugs, they usually take some time for onset at lumbar levels. And as we all know, natural thoracic kyphosis at thoracic levels T765. There are some safety concerns whenever we talk about segmental spinal. The first and the foremost is neurological injury with dural puncture at mid to lower thoracic or high lumbar levels. Can there be injury to the spinal cord? The second issue is ventilatory impairment due to extensive thoracic nerve blocks. And third is bradycardia hypertension. And the last but not the least is medical legal issues, as it is still to appear in the standard textbooks. The major concern is damage to spinal cord. This is midline MRI of the spinal column. The cervical enlargement feeds the entire spinal canal at the level. In the thoracic segments, the spinal cord is positioned anteriorly, leaving a significant space between the posterior dura and the spinal cord. At the lumbar level, the lateral space disappears almost completely. It will be clear in the next slide. Here you can see clearly there is sufficient space to accommodate your spinal needle at the mid-thoracic levels for giving a segmental spine. This is position of the spinal cord at various levels at thoracic, thoracolumbar, and cauda inguinal levels. Imbeloni and Guvia did a study on the low incidence of neurological complications during thoracic epidurals, and they provided anatomic explanations for this by measuring the exact distance at various levels at T2, T5, and T10 levels. And they found the distance to be around 5.19 millimeter at T2, 7.75 millimeter at T5, 5.88 millimeters at T10 levels. Then again, Lee R. did study on the anatomy of the spinal, thoracic spinal canal in different positions, and they found the distance to be more in all positions, especially the lateral and sitting positions at mid-thoracic levels between the posterior dura and the spinal cord. Lateral and the sitting positions, these are the positions we usually use for giving spinal anesthesia. The spinal cord lies ventral in the apex of the thoracic curve when the spine is flexed at thoracic levels. You can see on the left hand side the distance between the anterior dura and the spinal cord, and on the right hand side you can see the distance between the posterior dura and the spinal cord at thoracic levels. This is again midline MRI. Because of the angulation which is required to perform a spinal anesthesia at mid-thoracic levels, you need an angulation almost 35 to 40 degrees to perform spinal at mid-thoracic levels. The distance between posterior dura and the spinal cord is further increased. You can see here the distance is almost 8 millimeter as compared to 4.5 millimeters at T12L1 levels. There are some additional points which favor safety of segmental spine. The incidence of neurological injuries after accidental dural puncture during thoracic epidurals is very less, favoring the safety of intentional dural puncture. Many anesthesiologists unknowingly use high lumbar or thoracic spaces, especially in the obese and parturients. In one study, only 29% were found to be correctly identifying the required intervertebral space. The level at which the spinal cord terminates is also variable. It can be as high as T11 or as low as L3. What that means is you are already using these thoracic spaces for giving spinal unknowingly. To accurately identify the correct interspace, ultrasound, you can do it correctly. Otherwise, the correct identification is only in 29 to 41% of the cases. You are always one or two spaces higher than assumed. The intercrystal line interspace is also variable. A second issue about segmental spinal was ventilatory impairment. Here, the main inspiratory muscle of respiration is the diaphragm, which is usually unaffected. Expiration at rest is a passive process. Forceful expiration and coughing may get affected due to paralysis of anterior abdominal wall muscles. But as the doses used are very low, That usually preserves the cupping ability due to minimal motor weakness of abdominal muscles. It is mostly a sensory block. Bradycardia hypotension, the heart rate may decrease if block extends T1, T4, blocking cardiovascular fibers. But due to lumbosacral sparing and less venodilation in the lower limbs, the right atrial filling is maintained and the negative bend bridge reflex is not initiated. That usually sustains the outflow from intrinsic chronotropic receptors and that maintains the heart rate. Less hypotension is because of the less sympathetic blockade and less venodilation in lower limbs. About the medical legal issues and litigations, now there is enough evidence to prove its utility in cases where it is most indicated. Recently, it has also appeared in the British Journal of Anesthesia. Most cases of litigation are against regional anesthesia, but still the thoracic epidural is being performed day in and day out. Proper explanation to the patient and consent is a must before you go on for segmental spinal. It has started to appear in some textbooks, but till that time, we can keep our fingers crossed. Feasibility of segmental spinal and utility. Technically, it's not much difficult when due precautions are taken. Economic, it's very, very economic. Legal feasibility is still a question mark, but can be defended with strong indications. Operational feasibility for it has a good learning curve for experienced physicians and can be used for practically all intra-abdominal surgeries like upper, lower, open, laparoscopic, minor, major, even for breast and superficial thoracic surgeries, plus some awake thoracoscopic like bulectomy, thymectomy, lung volume reductions, and wedge dissections. Also can be used for some prone and lateral position spine and musculoskeletal surgeries. Some advantages over routine spinal or at times over general anesthesia. The surgery is thought to be out of domain of spinal anesthesia, possible with segmental spinal, like upper abdominal, thoracic, and breast surgeries. High levels of the blocks can be achieved with just half the dose that is required at lumbar levels. There is minimal hemodynamic fluctuations, early recovery and voiding. Special advantages over general anesthesia in patients with respiratory comorbidities and can avoid post-op pulmonary complications and ventilatory support in such cases. There is also lower incidence of post-op nausea and vomiting. There are three different modes of using segmental spinal. Either it can be a single shot segmental spinal for short duration surgeries up to 120 minutes, or it can be combined with epidurals, either for long duration surgeries or as a backup in a very morbid ill patients when you want to use a very low doses for segmental spinal. In that cases, your epidurals can be handy not only as a backup for segmental spinal, but by epidural volume extension technique, you can spread the low intrathecal drugs to wider segments, and also the epidurals can be handy for post-op analgesia. The third option is continuous segmental spinal anesthesia. In case you have accidental dural puncture during thoracic epidurals, you can continue with this technique, or in very morbid cases, you can use it as a primary technique using spinocats by giving titrated and sequential boluses in morbid cases for long duration surgeries. Either isobaric or hyperbaric drugs can be used. Even a combination of hyperbaric and isobaric drugs can be used in some abdominopelvic surgeries. In general, isobaric drugs are preferred for laparoscopic thoracoscopies, breast and superficial abdominal or major intra-abdominal procedures in morbidly frail patients. Hyperbaric drugs can be a choice in some male muscular patients for open surgeries where relaxation can be an issue with isobaric drugs. There are some advantages of isobaric drugs. They are less sensitive to position issues. In low doses, they have propensity to block sensory nerves in preference to motor ones. It is also labeled as a selective anesthesia. Onset is gradual. There is hemodynamic stability even with higher levels of block. Motor block time is shorter, leading to early ablution and voiding. Spinal can be given directly in the operative positions, like for some lateral position surgeries, or patient can turn on his own immediately after spinal to desired positions, like for some prone position, spine surgeries, or like that. The spinal can be given before epidural and a space higher than epidural without worrying for unilateral effects, which can happen when we use hyperbaric drugs and use spinal before the epidural. There are some disadvantages also. The levels of block cannot be modified by any change of positions. Drug needs to be placed at the precise dermatomes. Like in epidural, sacral sparing is common when low doses at higher spaces are used. Takes some time for onset at lumbar levels. There is slightly less muscle relaxation, so may need higher doses in male muscular patients. They are also sensitive to temperature variations and at times can have unpredictable results when there are wide variations in temperatures. Amongst the available drugs, isomeric drugs like chlorprocaine 1%, levobuprofen 0.5%, ropivacaine 0.5 and 0.75%, or the hyperbaric drug like bupivacaine 0.5% and now ropivacaine 0.75% can all be used. Chlorprocaine is not available nowadays, but it was a very good drug, being 1%. The volume required was slightly more, but it was very good for very short duration surgeries of 40 to 60 minutes, either open or laparoscopic. Levobuprofen 0.5 and ropivacaine 0.75% are comparable. Ropivacaine being less lipid soluble is nearly half as potent as levobuprofen intrathecally, and there is stronger differentiation between sensory and motor blocks with ropivacaine. Addition of small doses of additives like fentanyl, dexmedetomidine, ketamine, or clonidine can intensify the sensory blocks. Dexmedetomidine providing a longer duration than others in a dose-dependent manner. And ketamine, though potentiating sensory block, is known to shorten the motor block time. Bupivacaine heavy and ropivacaine heavy can be used in the same dose range as isomeric drugs. And the thoracic segmental anesthesia can be produced with just half the dose than that is used at lumbar levels. Gravity-dependent spread has to be kept in mind while using steep tilts for lap surgeries and can be a better choice for open surgeries. This is important. How to decide the dose and the site of injection? For abdominal surgeries, it depends on the type of surgery, site of surgery, average duration of the surgery, and whether the patient has any comorbidities, and whether it is combined with epidurals or not. Dose of local anesthetic and the site of injection along the nerve axis can be varied. But in general, the 1 ml of isomeric drug spreads 2 to 3 segments above and below the site of injection. What that means is 2 to 2.5 ml of the drug is sufficient to block segments from T2 to L5S1 if spinal is given at T10. Then thoracic space lying in the center of the surgical field for upper abdominal surgeries. You can take this as a gross statement for all your ASA12 patients for all intra-abdominal surgeries, 2 to 2.5 ml drug around T10 level, and that will be sufficient for all intra-abdominal procedures for ASA12 patients. With adequate dose, space about T10 is hardly required. Space between T10 and L1 at a dose of 2 to 2.5 ml with some additive works nicely for 90 to 120 minutes. With this much of dose, and if you are using the additives like fentanyl or ketamine, then the regression of effect from lumbosacral root starts varying after 70 to 80 minutes. And for surgeries which involve the pelvic manipulations, if they go beyond this time, then a combination of hyperbaric and isomeric drugs can be used to prolong the effects at lumbosacral roots up to 2 hours. For breast and superficial thoracic surgery, spinal at mid-thoracic levels, T456 with 1.2 to 1.5 ml and some additive is preferred, but even up to 2 ml can be used if you want to do a breast surgery with the rectus abdominis flap. Then you can use 2 ml at a little lower space for giving spinal. With this much dose, it can provide a duration up to 60 to 90 minutes or little more if dexmedetomidine is used as additive. For prolonged procedures, better to combine with epidural or some blocks rather than increasing the intrathecal dose to avoid the adverse respiratory and cardiac events. These are the levels which are required for different types of breast surgeries. Like for MRM, you need C5T7, mastectomy with transverse rectus abdominis flap, you need levels from C5 to L1. For partial mastectomy in breast augmentation, T1 to T7. Epidural scoring scale for arm movements, which is used to assess the thoracic epidurals, can be well used for assessing the motor block in segmental spinal. Hand grip is C8T1, wrist flexion is C8C7, elbow flexion C5C6. Position of the patient working spinal. With isobaric drug, it does not matter. Lateral sitting or even prone position can be used. Plain UVP again, which is specific gravity of 0.9990 is slightly hypovaric side. Given in sitting position, and if the patient is kept seated for some time, can lead to high levels of the block. Temperature of the drug has inverse relation with paricity, especially the isobaric drugs. Cooled at 24 degrees, so with a density of 1.0032, can become slightly hyperbaric, and warmed at 37 degrees can become hypovaric. Wide variations in temperature can have some impact of gravity on the spread of drugs. When you are using two-drug technique, sitting position is mandatory for giving spinal initially. Type of spinal needle, either Quincke or pencil point, can be used combined with epidural. CAC kit is the easiest and safest option. The rate of paresthesia is more with pencil point needles, as you have to enter more in the CSF to have a free flow of CSF, around 2 millimeters more than your cutting needle. So the incidence of paresthesia is said to be more with pencil point needles. But in the study, all paresthesias were transient with no neurological complications afterwards. Landmarks to identify thoracic intervertebral spaces. You can do it manually by palpating the landmarks, like the C7 has the prominent spinous process. The root of the spine of the scapula corresponds with T3, inferior angle of the scapula with T7. The lower rib margin is around 10 centimeters from the midline of L1, and this apart from your Tophius line. Or you can use ultrasound. You can count upwards from L5S1 in parasagittal oblique view to calculate the exact space for viewing spinal, or identify the 12th rib and count upwards, or identify the first rib and count downwards. There are some anatomical hurdles for thoracic spinal. The thoracic spinous processes are sharply angled and point caudally between T4 to T9, and beyond T10 they usually resemble those in the lower region. Interlaminar spaces in the thoracic spine are narrow and more challenging to access with midline approach, so a pyramidine approach can be more useful at mid-thoracic levels. These are some tips to follow for giving spinal at mid-thoracic levels for pyramidine approach. Ultrasound imaging of the thoracic spine, where there is very small window in the parasagittal oblique view, and there is absolutely no window in the transverse view. The ultrasound of the thoracic spine is not as easy as it is at the lumbar levels because of these angulations of the spinous processes. What ultrasound tells us is the location of interlaminar space, the depth to interlaminar space, and where exactly the midline is. Many times there is kyphosis of scoliotic spine. In scoliosis, the convex side is said to be more open for giving spinal. This you can identify with the use of ultrasound. Parasagittal oblique view at the mid-thoracic spine to localize the ligamentum flavum dorsal dura complex. We can know the depth of the interlaminar space. Transverse interspinous view can have oblique view, but this view is not very useful at mid-thoracic levels. There are some safety measures for successful use of segmental spinal. You need to do a preoperative assessment as to the type and the site of surgery, approximate duration of the surgeries, what are the dermatomes involved in the proposed surgery. If ultrasound facilities are available, you can do a pre-procedural scan. Identification of the landmarks to locate the intervertebral space for viewing spinal. Selection of the proper drug and mode of segmental spinal. Decision on the site and dose of drug required. After giving spinal, assessment of the levels achieved, monitoring, and use of appropriate sedation as per need. In the preoperative assessment, apart from the site and the type of surgery, you need to know whether it is short duration surgery, mid duration, or a long duration surgeries, and what are the comorbidities of the patient as to the feasibility of segmental spinal alone, or you want to utilize epidural along with spinal to have the flexibility of using a very low doses in the segmental spinal. Or the third option is you can utilize the continuous segmental spinal anesthesia using spinal caps. These are the dermatomes involved in the proposed surgery. You need to know beforehand. Like I said in the MRN, the dermatomes involved are from C5 to T7. Coming to my segmental spinal profile, more than 3,000 surgeries, last almost 10 to 12 years now. Initially for high-risk cases, but now profile is nearly 50% of my SEBI profile. Till date, there have been very few partial failures, but no mishaps. I usually do a complete pre-anesthetic evaluation of the patient when a success, minimum mandatory monitoring, no sedative pre-medications is used, lateral decubitus position with 27 gauge Quincan needle. The speed of injection is average, around 1 ml per 15 seconds, depending on the patient's parameters, the site type of surgery, the dose of local anesthetic, and site of injection is selected. I used to use chlorprocaine for short duration surgeries, but it's not available now, so I use levobuprofen only. For mid duration surgeries, 60 to 120 minutes, either levobuprofen 0.5, ropivacaine 0.75%, or heavy drugs like bupivacaine or ropivacaine, along with fentanyl or ketamine or dexamethasone in the range of 5 micrograms to 10 micrograms, according to the duration I want to achieve. For longer durations, you can use dexamethasone. Dexamethasone can provide you a duration more than around 2.5 to 3 hours with the same doses of the drugs. And for average female patient, 2 ml plus additive. For average male patient, 2.5 ml plus additive. T10 to L1 interspace is usually preferred. Combined with epidurals, initial dose can be kept to a minimum to around 1 to 1.5 ml. I usually combine it with some block like transverse abdominis plain block, rectus sheath block, or erector spinae plain block for open surgeries, or LA at a port site for laparoscopic surgeries. For breast surgeries, as I already told you, mid-thoracic space is used and isobaric drugs are preferred. I usually combine with epidurals or some blocks. Recently, I started combining it with erector spinae plain block with full concentration. I combined the segmental spinal with erector spinae unilateral plain block with full concentration of drug. That is giving me very good results. Instead of epidurals, I am combining these two techniques together. Coming to two-drug technique for surgeries like TLH, PCNL, colorectal, or other surgeries where dense and anterior effects at lumbosacral roots is needed and which cannot be achieved with using low doses isobaric drugs alone at thoracic levels. It can be used even for some high-risk LSS cases, gynec and ortho surgeries also. For this, you need to give spinal in the sitting positions with 0.5 to 1 ml of hyperbaric drug bupivacaine initially, followed by 1.5 to 2 ml of isobaric drug according to the patient and his comorbidities, with some additives in different syringes, hyperbaric followed by isobaric drug. Patient is usually turned supine immediately after spinal or kept in lateral position for lateral position surgeries. Sensory block tested by pinprick usually sets in 3 to 4 minutes. Some hemodynamic fluctuations can occur in first 10 minutes, but these are usually minimal and gradual. No respiratory embarrassment is seen even with the high thoracic or cervical root involvements. Initial partial involvement of lumbosacral roots can occur depending on the dose you have used, but usually recovers at the end of surgery. No additional supplements are usually needed. In laparoscopic surgery, at times when the levels are not adequate, you may need some sedation. Patients can be completely immobilized in 4 to 6 hours. To sum up, it is a very useful technique with many advantages, minimal risk with due precautions. No need to panic, even if the block level is found to be higher than desired. It's mostly a sensory block. Lap surgeries may need little sedation. When facilities are available, ultrasound can be helpful for more safety. Technique is reserved for experienced clinicians with good learning curve. Now I'll show you some short videos. The first one is a very simple how to perform spinal at lower thoracic. I think case of umbilical hernia. I usually use 27 gauge needle at in lateral position. These are spaces as straight as your lumbar spaces, low thoracic spaces. Not much of angulation is needed. This is a morbid obese lady, around 132 kg for hysteroscopic removal of the polyp. And the procedure was supposed to go on for around 45 to 60 minutes. The spinal was given as per drug at T12 L1 level in sitting position because she was very morbid obese. The video is not very clear. It's a very old video. The same patient after 1 hour, patient completely moving her legs in the recovery. And this is after 3.5 hours, she was completely mobile. This was a recent case which I did 15 days back with a serum creatine of 4.7, new perforation, old man of 80 years old, new perforation some 3-4 days old. I did it with heavy bupivacaine 2 ml at around T9-10 level. Whole abdomen was filled with it. This is MRM which was done long back under combined epidural and spinal. Epidural was put at T5-6 and spinal was given at T6-7. Levels being tested. You can see how comfortable the patient is even with such high levels of block. She had no sensation at C8, but her grip strength was good, indicating only a sensory block. This is MRM being done in the same patient. Whenever you are not given any epidural or some block in MRM patients, you can ask the surgeon to give PEC1, PEC2 block under vision. This is PEC1. Patient is giving between pectoralis major and minor. This is another PEC2, pectoralis minor and serratus anterior muscle. These blocks can be given under vision for post-op analgesia. This was traumatic diaphragmatic hernia in a young male, 35 years old, done under combined segmental spinal and epidural. Probably it was the first time it was done under whole regional technique. You can see whole of the intestine was in the left hemithorax. Diaphragmatic mesh repair being done in the same patient. Same patient at the end of surgery. Complete reparation of segmental spine. The next day X-ray of the same patient, complete expansion of the left lobe of the limb. This was a huge obstructed umbilical hernia. You can see his respiration was done under combined epidural and spinal. The big transverse incision. Procedure went on for almost 3 to 3.5 hours. This is laparoscopic cholecystectomy in a morbid old lady, diabetic hypertension with ETCO2 monitoring. It was a very huge ovarian cyst which was compressing all the intra-abdominal structures and was supposed to be malignant. And she was a morbid old lady with comorbidities. So it was done under two drug techniques. Spinal was given at T12L1, 0.5 ml of the hyperbaric drug initially, followed by 2 ml of the isobaric drug at the same level. The cyst had to be ruptured as it was very huge cyst. Even with the full length incision, it was not possible to be removed intact. Her cystectomy, omentectomy, and hysterectomy was done. This is again MRM, the combined spinal and epidural. The spinal had to be given by paramedian approach. It was not possible by midline approach. After epidural, the spinal was given one space below. You can see MRM being done. This is axillary dissection being done. The same patient at the end of surgery, shifting herself. She was already given chemotherapy. She was a very morbid ill patient. This is TLH under two drug technique. You can see at the end of surgery, the patient has complete restoration of effect in the lower limbs. This was an old man with a CA vocal cord. Upper GI showed near total occlusion at the post-cricoid region, posted for feeding gastrostomy. It was done with a single shot spinal at T8-9 level, just 1.5 ml of the drug. This is PCNL, which was done with two drug technique. This is a ruptured ectopic. Almost more than 30-40 cases which I have done of ruptured ectopic under segmental spinal. Whole of the abdomen is filled with blood. You see the blood has extended up to liver also. This was a patient for TLH. She was having a tlatinoaxial dislocation with bacillary invagination, and her C1, C2 fixation was done. And she also had these bulges at C4-5 levels. She was having some tingling numbness in the upper arms, and she had limited mouth opening because her C1, C2 fixation was done. And she used to get vertigo while with neck movements. So in pre-op counseling, I gave her the option of segmental spinal, and she happily accepted it as she was more worried for her neck movements. And she was a relative of a doctor also. So it was done with two drug technique. This was a CA rectum, which was done some 6 days back under combined segmental spinal and epidural. And after 5 days, the patient developed dehiscence of the colorectal anastomosis. And he was again given segmental spinal for this laparotomy. You can see his abdomen is filled with blood. He had bilateral pneumonia by that time. You can see his parameters, pulse rate of around 158. These were initial parameters. This was a ruptured liver abscess in a young female with a hemoglobin of just 4.9. Her CRP was also raised. And because her count was more than 48,000, so it was done with a single shot segmental spinal. The whole of the abdomen was filled with pus. This is obstructed inguinal hernia. It was done under segmental spinal by laparoscopy. TAP. This is usually how I monitor EtCO2. Whenever the probe is not available for monitoring EtCO2, I cut the 12 gauge nail cap tip and attach it to the EtCO2 port. This is simple appendicectomy with EtCO2 monitoring. Same patient shifting herself at the end of surgery. This was volvulus of the small intestine because of this polyp, Meckel's diverticulum, which was very big. That was causing all the trouble in a young male patient. It was done with a hyperbaric drug. Laparotomy was done with 2 to 2.5 ml of the hyperbaric drug, almost to get gangrenous. This was again the perforation leading to obstruction in a very old morbid patient. It was done with a single shot segmental spinal. These are two patients being interviewed, one during surgery and one at the end of surgery, laparoscopic surgery. This patient is being interviewed. These are my two publications on segmental spinal. One is in International Journal of Anesthesiology and one in Indian Journal of Anesthesia and Analgesia. And thank you very much for patient listening. I hope I was clear all the way.
So superb presentation and based presentation.
Thank you.
Any questions from audience?
Actually, it has been presented
Abhijit
on so
Nair
many
sir
times.
has raised hands. Please, sir. Abhijit sir, please.
Yes, sir.
Good evening, sir.
Good
It
evening.
was an excellent presentation.
Yes.
Many of our doubts
Thank
were
you.
cleared actually after
you.
Listening to your presentation. Sir, I wanted to ask one thing. Like I follow your post also in Facebook, and I also follow Dr. Starnari's post also.
Okay.
So what I have seen is he, along with local anesthetic, he adds opioids, midazolam, ketamine, and a lot of mixtures, basically a lot of adjuvants. So do
Yes.
you recommend, or what is your experience in that? Because I was a little worried. So many things in the thoracic area.
that's
how safe it is?
what first and foremost is so many drugs, opioids are not available with us, and what we are doing is mostly a single shot segmental spinal for short to mid duration surgeries, for mostly for freelancers, and what they are doing is critical care surgeries like long surgeries in the morbid ill patients, and their patients are mostly from critical care unit. They can afford to have their patients immobilized in the ICU setup. But what we do is mostly a daycare surgery. So we are not using not more than a single additive at a time. As you said, I am also operated to use more than one additive at a time.
Thank you, sir. Thank you very much.
You don't need to observe these patients. As you have seen, most of the patients, they shift themselves from table to stretcher with so much of additions. Even if you add Dexmit, just rinse the syringe, the patients are immobile for almost 2 to 3 hours. And addition of dextromit, ketamine, and so many things will keep them immobile for almost 5 to 6 hours.
Got it, sir. Thank you.
Sir, next question from Dr. Someshwar Patangi, sir, our president-elect.
Yeah. Hello, sir.
Hello, sir. How are you? Seeing
fine,
you after
fine.
long, after 100
Yes.
conference.
Yes, sir.
Sir, one question is there. that whenever I use dextromid with the as a adjuvant in spinal, there is so much of bradycardia and hypotension.
How much do you use? I mean,
Yeah, it's a smallest, as you mentioned, 0.2 microgram and something. It is
do
same,
you
but the
calculate
bradycardia is there.
exactly, or
Whenever,
how do you
yeah,
calculate the dose? I mean,
yeah, because
with 1
whenever
ml
you
syringe?
add as a additive, there is always brady and hypotension. Have you
Right.
observed it, or it is happen with
Yes,
me only?
it it does happen, but many times what happens, the dextromid it comes in 0.5 ml ampoules or
Yeah.
1 ml ampoules, and you
Mhm.
need to calculate exact dose by using either a BCG syringe or a insulin syringe. Most of the
Mhm.
time, what we do is we take an approximate dose, and that is more than 10 mcg.
Mhm.
That
Actually,
unnecessarily prolongs
I
the.
just used to flush. I use it like just like as
Even
an additive.
after flushing, depends on the dead space of the needle and the syringe. Most of the
Mhm.
times, it is more than 10 mcg. What I have observed, it is even one drop is, I think, more than 5 micrograms. What we
Okay.
see in the syringe.
Yeah,
So
and you are using how much you are calculating as a 0.2 microgram?
I used to use this tuberculin or this insulin syringes for exact measurement of the dose. If you have that 1 ml syringe, you can take the drug and then zero point 0.1 ml of that in your syringe.
Okay.
Suppose it
And
is
there is
50
no
micrograms.
brady or hypotension. With
No,
using this, there is no brady.
it usually occurs
Mhm.
even with this much of dose, but it is manageable. It's not much. Like 2 3 days back, I did one TLH, and that patient had some previous seizure. She was nulliparous patient, and it was expected that it may take some long time. So I did dextromit and did it in two drug technique. The effect lasted for almost 3.45 hours for a complete duration of the surgery
Yeah.
with just 2 ml of isobaric and zero point 0.5 ml of hyperbaric drug. And dextromit just rinse the syringe with dextromit.
Yeah, duration is definitely raised, and for
Definitely,
duration we
yes.
can use it. Yeah.
So fentanyl is very good, but only issue is itching.
Mm-hmm. Right, sir. Okay, I will use BCG syringe. Thank you very much, sir.
Exact calculation, you may not see this problem
Mm-hmm. Okay, sir. Right.
because you must
Thank
be
you.
using 5 ml syringes, no?
No, we are
Or
using 2 ml syringe, and
okay,
I'm taking just 0.1, and then I'm flushing it. I'm not using it, but still after
uh,
flushing also I experience hypotension and bradycardia. Then I stop. Actually, it happens for 4 5 cases. Then I stop. I
okay,
have to use
okay.
adrenaline or
It
even in one case, small dose.
it is usually not needed, but it can
Mhm.
happen. Brady and hypotension.
Mhm. Yeah. Oh, thank you, sir.
Thank you.
Any questions from audience?
Dr. Tarun has joined. Tarun
Yes, sir. Yes,
Wadela.
sir.
Good
Yes, sir.
evening. Next month we will be having a live workshop at PDMC Amravati. I have also called Dr. Tarun and Dr. Rajesh Shah
Okay,
as
sir.
a faculty for our workshop. If anybody wants to join, I will send the link after 20th of this month.
So we would very much happy if you come at Nanded for workshop. You have, I don't think, but it's a personal question.
Uh,
Uh,
you can
should I take?
join with us in Amravati. It's not far away
Yes, sir. Yes,
from
sir. It's
Nanded.
but
Next month we will
or
be having a workshop.
maybe we will come. We will take on next month at
Right.
GMC Nanded. I have taken all permissions from Dean. They are happy to
Uh,
come.
the
He was very much happy.
only issue is I am not available after 15th of this next month till 15th of July. I'll be
Okay,
going to
sir.
my son's place at US. So
Okay, sir. So after July, we will.
Yeah, after that you can always plan that.
Okay, sir.
We'll be happy
So,
to be there.
thank you, sir. You mentioned about your Amravati workshop. We are planning on basically next month. But
Okay.
we will do in July or August, something like that.
Dr. Tarun will tell about the experiences of last workshop we did at
Please,
Navsari.
please, sir.
That was,
Please, sir. Tarun, sir, please.
just unmute him.
Yes, yes, sir. I will unmute him and will pin him so he can speak his experiences.
He can unmute himself, na?
Yes,
Dr.
yes.
Tarun, please unmute. Yes,
Okay, sir.
thank you.
Can you hear?
Yeah, we can hear you.
Yeah.
Go ahead, sir. Go ahead, sir. Please.
Yeah. Last month on 13th of April, we have conducted 5 live surgeries uh, with the faculty of Naresh Paliwal sir and Rajesh Shah sir. All patients we have selected that one surgery of TLH, one surgery lap chole, one open umbilical hernia, one MRM, and last one is piles hemorrhoidectomy for hypobaric for demonstration of hypobaric drug. And Sir Paliwal sir has nicely demonstrated that also. And all the patients were pain free, and after 1 hour, all patients were walking in the ICU. So we have conducted successful segmental spinal workshop. That was the first workshop in the, I think, in the world,
Yes, sir. Yes,
because
sir.
no one has conducted live workshop till date. Sir
Yes,
has,
definitely, definitely.
sir has given almost more than 25 live this discussion or seminar or CME, whatever you call, in last this couple of years. But live we have conducted first time with the help of the and guidance
That
of
was
Paliwal sir.
that was all
Please.
because of Dr. Tarun. I was actually reluctant to do a live workshop on this subject, but it was the himmat of Dr. Tarun.
There is the
Now, because of that, we have planned another workshop with the same faculties at Amravati. Let's see how it goes.
Paliwal sir is Bhishma Pitama of this segmental.
Really, really, Vishmapata. Vishnu Pitama of segmental spinal. I'm really eager that he should come at our place in Nanded, and we will do one workshop.
So actually, this kind of CME is okay. Just we will enhance our knowledge only. But whenever we see the live, then that will definitely give a good result. Total we have registered 130 delegates, and out of that, more than 100 have tried this segmental in last month, and most of them, 99% are success.
Sir,
So
basically, my motto is for private forum anesthesiologist. They should see these CMEs and case meets, and you are the pioneer for this. And
This is
almost
mostly useful for private freelance practitioners only,
yes,
because
yes, sir. I
in
am trying for
institutes,
that only, that our private forum people should know, and that topic I am including my case meets only.
it's a very
And
helpful in day-to-day practice in private setup, and in institute also it will definitely work for the very high-risk patients and all these things.
yeah, there are many people in the institutes also who have done this segmental spinal in selected patients. Even if you don't do it for all your cases, if you know this technique, you can utilize it for your required category of patients. It's very helpful.
And Dr. Tarun, happy to share you that the first time Dr. Naresh Paliwal sir presented this segmental anesthesia at Maharashtra level in Nanded conference.
Yes, yes.
Okay, yeah.
That was
Okay,
in
okay.
2015, I think.
Oh,
2016, sir.
16. Oh, way back, 7 years back,
Actually,
6 7 years
actually
back.
Yes,
before
yes, yes.
that, actually before that, I gave my presentation to Evra at 2015 for for presentation, but they did not accept it.
Yeah,
So I
yeah, yeah. You
presented
told
it.
that you are presented, but at state level you came at Nanded in
I did not.
2017,
They didn't
and
accept my
first time in
presentation.
Maharashtra level that we had discussion at that time. I still remember.
Yes, yes.
Yes, yes. Thank you, sir. Thank you very much. Yeah.
Now they will invite us for the workshop.
Definitely. Now he is, you said na Pitama, he is Pitama Bhishma of this segmental anesthesia. And
Definitely, definitely, sir.
yeah, we should hope that this segmental anesthesia concept will come in the textbooks very soon.
It has
Uh,
recently
it
published
will
in
come on.
BJ, British Journal of Anesthesia. They have recently put an article.
Sir,
Mhm.
this topic is really worth for private forum and one of the best topic.
It definitely
Only
it works very very good. Patients very
really,
remain very comfortable. There is no complication till date.
yes, yes.
And whatever the complications for the spinal, we are master in managing all the complications of spinal.
Actually, I was thinking that this topic should be that last topic should be this one, but anyhow, uh, sir is free now, so I decided to keep this topic now. This month is very much. What can I say? This is the best month, like Bhim Jayanti, Ram Navami, Hanuman
Yeah,
Jayanti,
yeah. A lot of
Dasharat, a lot of good things happening in.
Festivals, sir.
So I decided that sir's topic should be kept in this month only. So I decided and I kept. Sir, you can please mute yourself. Tarun sir, please.
Yes, sir.
Any other question
Hello.
from audience, please?
Hello.
Yes, sir.
What is the question?
No, sir. I'm just asking to audience. Any question from audience?
No, no, no.
this presentation is now available everywhere, so I don't think people should have any queries about
So
this.
we are keeping this on YouTube also. That's
Yes,
no
this
issue,
is
sir.
my 26th presentation on the same topic last 2 years. Leave apart the initial presentations which I presented since 2010. There were
You are
So,
the
only
inspiration,
five
sir.
six
sir,
only
sir, know
five
all
six presentations.
questions. So he has included all the answers in the his presentation only. He knows all the questions.
Yes, I know, sir. Uh, Basically, my question was, you work in someone unknown has raised a hand. Please ask your query. Unmute yourself and please ask. Sir, Tarun sir, please mute yourself.
Hello. Hello.
Yes, continue.
Ah,
Uh,
yeah.
Sir, how much is the post-dural puncture headache? Because the patient start walking immediately after 1 hour. So, is there
Yeah.
any incidence of post-dural puncture headache?
Post-dural
Sir,
puncture headache.
before answering question, I want to know who is unknown person. Please introduce yourself also.
This is Dr. Shashi Patil from Latur.
Latur. Okay.
Yes, sir.
Okay.
Okay. Sir, please continue.
Now, I usually use 27 gauge spinal needles for all my patients, whether it is
Okay, sir.
segmental or lumbar spinals. So the incidence
Ha,
is not nil, but it's very less, just 0.1%. You may say once in a blue moon, like once in a year, the patient complains of this. Most of my patients are mobile within 3 to 4 hours, whether it is a segmental spinal or any other spinal. Even we discharge some TL or laparoscopic MTPTL patients after 3 to 4 hours. The incidence is there, but it's not very much, just 0.1%.
okay.
So it depends. It's just like for any other spinal.
Okay. So, is there any need to keep the patient head low after
No,
after the procedure only?
no, not at all. We have stopped it
Okay.
since last 30 years. We don't keep any of our
Okay.
patients head low after spinal.
Okay. Sir.
That is a actually wrong concept. Is going on since ages. You just hydrate the patient if you are scared of post-dural puncture. Just ask to take rest, take plenty of fluid. There is dist and maneuver also. if you have seen, distance maneuver are the exercises which the patient can do to prevent this posterior puncture headache. The SPG block, which spinopalatal ganglion block, that also works very nicely if at all there is a posterior puncture headache. These are all minimal invasive techniques which can be utilized to treat the posterior puncture headache.
One point I want to add it, the arrangement of dura fibers in thoracic levels are very dense. So the chances of leakage are very less as compared to lumbar level. Even with the 18 gauge epidural needle, if you puncture accidentally dura, there is no reported of PDPH in that incidence also.
Basically, the amount of CSF is very less at thoracic levels compared to that
that is
lumbar
also
and
one extra point. Yeah.
And post-dural puncture headache is most common in young females and parturients. In old morbid patients, most of the times when you utilize segmental spinal, it's not very much there. I have used this technique even in kids, segmental spinal. And after the workshop, many people have used this even for VAT surgeries, video-assisted thoracoscopies, and I used it only once, but many people after the workshop have used this technique for VATs also.
The role of derifylline in this dural puncture headache?
Oh, I don't think there's any role for derifylline. If it is there, it is just empirical.
Okay, thank you, sir.
Sir, I want to know, as we are a private forum anesthesiologist, we work in very much
low resource.
Yes, low resources places. And what do you think? Segmental spinal, and there is no tuberculin syringe. What do you think?
No. Tuberculin syringe is not needed for all additives. It's just for dextromid if you want to calculate the exact dose. Even if you rinse the syringe, just rinse the syringe and put all the amount back into the ampoule. Whatever remains in the needle dead space is around 3 to 5 micrograms. You have to be just cautious not to take an extra drug. Otherwise, the tuberculin syringe, BCG syringes are not needed for any other additives. You can use your other 2 ml syringes or even 1 ml syringes.
Okay. Related to the heavy and isobaric, any experience on that?
For what?
For
the heavy, you see, the heavy drugs are more predictable. What I can say is these are time-tested drugs and they don't have any variations with temperature, because the difference between the CSF and heavy drugs is very much. I mean, there is a vast difference between the density of CSF and hyperbaric drugs. And the difference between the isobaric drugs and CSF is just marginal. I mean, they are on the verge of being hypobaric, these isobaric drugs. So a little fluctuation in the temperature or say some additive can change their varicity. Like if you add some fentanyl to isobaric levobupivacaine, fentanyl is hypobaric, and levobupivacaine, which is also on the verge of being hypobaric. So these little things can change the varicity. I mean, there can be unpredictability in the use of these isobaric drugs. While the hyperbaric drugs, there is such a vast difference between the varicity of CSF and hyperbaric drugs. Even if you add some additive, the varicity is not going to change. They will behave like hyperbaric only. I mean, they will be dependent on gravity for spread. There is main difference in these two drugs. And the relaxation part, the isobaric drugs, they produce more of a sensory blocks with low doses. So relaxation part is little less with isobaric drugs. You have to choose your drugs accordingly.
Okay. Sunil Dixit sir has raised hand. Please, sir. Sunil Dixit sir, please unmute yourself and ask your question.
हेलो सर, पलिवल सर, नमस्कार सर.
हेलो, नमस्कार.
नमस्कार सर, मेरे को ये पूछना था, फॉर TLH इफ यू वांट टू यूज हाइपरबेरिक बुप्रीकेन, व्हाट इज द बेस्ट लेवल ऑफ ब्लॉक and dose of the drug?
Best level of block means you can
At
use
which
in the
level?
same manner. I mean, what time your surgeon takes.
Okay, generally 60 minutes maximum.
Maximum 60 minutes. You can use just 2 ml of the drug at the same level as we use for other segmental spinals, T10 to T12 levels. But you have to keep in mind that you must be giving spinal in sitting positions.
Okay.
So the drug may drop down and you may not achieve adequate levels with hyperbaric drugs. If you use very low doses at these spaces, by the time you turn the patient to this thing, supine and then head low, and then again, if you use some higher volumes, then with steep head low positions with TLH, you can have very high levels.
Okay, sir.
So these are the few issues with hyperbaric drugs in such conditions. If you use isobaric drugs, you can give any amount of head low tilt without worrying for high levels of block.
So what you recommend, sir, position of the patient? It should be this lateral or sitting?
You can choose any position, but till the
Best
adequate level is used, achieved, you can give head low. Once the level of T2, T3 is achieved, you can make the patient supine for some time. And then after some 20-25 minutes, you can give any position. Provided your dose is on the lower side. If your dose is more than 3.5 or 4 ml, the extra drug can spread even up to 2 hours.
Okay.
Because of the bulk movement of the CSF, the extra drug can spread to high levels.
So 2.5 is sufficient, hyperbaric?
Yeah, 2 to 2.5 ml is very much sufficient with some additive.
Okay. Thank you, sir.
Okay.
Most of the time, TLH, surgeon needed head low position immediately after insertion of trocar. So they thought that level is achieved, so you should make that head low. And he asking a lot low head low, as we thinking that this much is okay for this surgeon, but that doesn't happen. So
yeah, most of the times what happens is even with the slightest of problems to them, they just change the position of the table or just increase the rate of insufflation.
Yes, sir.
I mean, whatever the technical fault is there, what they do is they increase the head low position. Then they increase the flow rate of CO2, increase the IAP. These are the things they do it first. So we have to be prepared for that. I mean, you have to keep a watch on whether the level is going higher or not with hyperbaric drugs.
Yes.
With isobaric drugs, you need not worry about the high levels of block even with 20-25 degrees of head down tilt.
Yes. I do regularly general surgery cases, and most of the time when surgeon is fatigued or he has some pressure on his mind, that time he asks no relaxation. This question is, that time I realized this is a difficult case for surgeon.
Yes.
What do you say,
the first
sir?
thing they blame is to blame anesthetist. There is no relaxation. There is no. With isobaric drugs, unless you tell the surgeon, they don't notice it most of the times. And if you say them that isobaric drugs will have some little relaxation, they will complain in each and every patient. I agree that it can happen in some obese muscular patients. There is less relaxation. But if you tell them this fact, then they'll complain in each and every patient.
So I do what, sir? I explain them that this patient is cardiac point of view is very risky. Still, I am giving, and you don't give. And I say them that you cannot get relaxation, and I cannot give this patient. Still, I am giving you on isobaric drugs. So he realizes, I have to do in this only.
Yes.
So he never asks on that.
You have to explain beforehand to the surgeon that these are the problems to the patient, and this much can be done.
Yes, sir.
In these much resources. Otherwise,
yes,
if this patient goes on general anesthesia, he may go on to ventilator and this.
You have to explain this.
Yes, you need to explain everything to the surgeon.
Yes.
Most of my surgeons initially, I mean, those recently joined new surgeons, they were not accustomed to these regional techniques.
Yes.
But they started calling me just for these regionals. Whenever they find that the patient is not fit for general anesthesia, they are now accustomed to doing it under regional. Most of the MRM and this thing, initially they used to complain about the cautery and all. The cautery used to jump. Then when I told them that you set the currents to a lower levels and then most of the time you use a bipolar cautery, the issue is solved.
Sir, this one is your 26th segmental spinal CME or case meet.
In the last 2 years.
Yes, sir.
Before that,
in Amravati, I want to just one simple part is that you are discussing this part since 26 episodes, and in Amravati, your juniors they are not doing this practice. Still, your surgeons are calling you only.
No, I am not practicing in Amravati. I am practicing in Paratwada.
Okay, sir.
I am actually from Paratwada. Okay. Most of my colleagues are doing it. Even in college, they are routinely doing it. Okay. It has become, I mean, for ortho surgeries, when I started using these isobaric drugs, initially I used to get the calls for all morbid ill cases for ortho surgeries. I actually don't attend the calls, regular calls for ortho surgeries, but for these morbid ill cases or DOT consent wale jo hai, I used to do that. But now, as everyone has acquainted this skill of using isobaric drugs in morbid ill cases, they are doing it.
Okay, so
for ortho cases, this is very useful.
Yes, yes.
You don't need to change the position. You can directly give spinal in the lateral position. There is very, very less hemodynamic fluctuations.
But time is very less, sir, in isobaric.
No. Time, adequate time. 1.5 to 2 hours is adequate time with 1.5 ml of the drug. If you additionally give a block beforehand, it provides a sufficient duration. And in such cases, you need to tell the surgeon this is time limit, or otherwise you have to use a epidural along with spinal for more safety. That again
you started
amounts
this,
to some.
Sir, I want to question you. You started this segmental spinal since a lot time, almost
2008-10.
Okay, almost 12 years, I think. So.
Almost more than 12 years.
So, any problem in 12 years? You think that this is our last boundary before?
Not till now.
Okay, sir.
What happened is initially I started doing it because residing at periphery, I used to get many patients from these tribal areas who were very bad patients.
Yes,
bilateral pneumonia, just 2 to 3 grams of hemoglobin, then due perforations and all. They are actually not fit for any sort of anesthesia.
Yes,
and if you don't do it, they just will take the patient to home, let them die. They'll not take it to higher centers. So doing such cases was initially without voice also. Now everything is available. Workstations are available. Almost everything is available with me.
Yes, yes.
But still, it's a useful technique in many cases.
Yes, I know this is very much a useful technique for private forums, but I want to know any limitations of these cases you recognize in your 12 years practice. You want to share on this? Anything?
Limitations, at times there can be some inadequate levels achieved you have to be ready to supplement. I mean, as such, there were no mishaps. Only thing is at times you can have a failure. I mean, either partial failure or complete failure. Maybe it's because of some technical difficulties. Only once I remember, I could not give spinal to one patient. 2-3 pricks I did, but I was not able to get the CSF. So I decided to quit and then gave general anesthesia. That was, I think, a regular patient, but somehow that day, that was not my day.
Oops.
Even with
This
2-3
happened with
pricks,
me
that was
also,
not.
sir. I prick almost 12 times to a pediatric patient. He is very much obese, and I'm not in that sense to prick this basically due to family problems or any other tensions. I did that, and finally I tell that surgeon that this case should not take today. We will keep on next day, and next day single prick, and I got
Yeah, these
CSF.
things can happen with everyone. When it's not your day, nothing goes right.
Yes.
You can have problems with the simple things.
Yes.
So it is a part of life.
Oral, basically, any questions from audience? I'm just lengthening interview with Paliwal sir. Basically, these questions are repeatedly I asked sir, and he tirelessly answered every question you ask him. Any question, literally, and that's the beauty of this person. So, anybody wants to ask any question, please raise your hands, because I am concluding this session now. Tarun sir, your any last word on this topic?
With the Dexmed, I have conducted 3.5 hours surgery with this segmental spinal. So there is no time limitation. You can add your adjuvant accordingly. So you can get the better effect and lengthy effect also.
Wow. So you
So
are also, we will keep one case meet on our ISA platform Nanded. I will contact you in a week or next week. Please
no
give
issue,
us
no issue.
some time on this. And
Sure,
sir,
sure.
Actually,
yes,
actually,
sir.
I am thinking of handing over all these these things to Dr. Tarun and Dr. Rajesh Bhai for further
No, no,
propagation
sir.
of the.
No.
What happens is I have some
Uh,
fixed ideas. Whenever someone new comes, he also has some new ideas. So things
Yes, sir.
can
Yes.
change actually. Now, recently, someone has posted about low dose isobaric drug at in lateral position. That worked as a hypobaric drug. Sohail Anjum, I think he posted on the Facebook group.
Yes, yes, yes. He's from
And
Nanded.
he said, Sohail Anjum is from Nanded?
Yes, sir.
No, I think, I
Maybe
don't know.
he's from, one Soil is from Nanded. I don't know he's
Okay.
Anjum or.
He thought it is isobaric, but it was due to hypobaric drug, actually hypobaric behavior of isobaric drug, which resulted in unilateral spinal.
Okay.
So these things can be done. These things can be done. I mean, there are many things like you can do even with regular spinal, you can do breast surgery if it is done in lateral position. I had done one male gynecomastia with hypobaric drug also.
Yes, sir. I
There are
also
many
did
things.
that. Yes, sir. Yes, I did that
Hyperbaric,
in.
nahi, hypobaric.
Yes, I did with hyperbaric.
No, hyperbaric, to many people, even somebody from Godia or Chandrapur, he has done a lot of cases. But there you need to spend some time, some 10-15 minutes in the
Yes,
unilateral
yes, yes.
position.
10, 15 times.
It is time
We did.
consuming. There is a lot of
Yes, sir. CA mastectomy we did with 1.2
hemodynamic
kV.
fluctuations also.
Yes, sir. Yes, yes.
You need to keep the patient in head low for almost 20 degrees head
For
low.
10 to, yes, sir. 20
Almost
minutes.
for
Needed.
15 minutes.
Yes, sir. Yes.
This is not a issue with isobaric drugs. You can immediately start doing it, and with a very low dose, just
Yes.
1 to 1.2, 1.5 ml of the drug.
So take home message from your side on this topic.
Take home message, you can start
Yes.
doing this in select cases initially where it is most indicated. I mean, instead of doing it in ASA 1-2 cases, you can start doing it in so that you can justify your, segmental spinal. And once you get acquainted with this, you can start doing it regularly. This is what I advise to everyone, because till the time it appears in the textbooks, no one should face any medical issues with this.
Okay.
That's the only problem. So even for that, I have kept the title of my workshop next month. I have not kept it segmental spinal. I kept it spinal anesthesia. Can it be different? And that will include even continuous spinal anesthesia, segmental spinal, and some details about how to use isobaric and hypobaric drugs. So it is a complete package of spinal anesthesia, which can be different from what we do regularly.
Can I suggest one ad or anything on this, sir?
Yes.
Sir, we are private practitioners, and if you want maximum private practitioner to come at your workshop at Amravati, please keep at weekends, because weekdays
it is
are
on
very
Sunday. It is on Sunday
okay.
only, 15th of May. It is Sunday.
Okay,
and
I'm
that
very
is the
much
only date
obliged.
available.
Please
that is
send
the
me,
only
sir,
date available
this
because
topic.
after that there is
I'm
exams.
eagerly to come to you, and
yes. I'll
like
send
me,
all the
most
details.
of the people are free on Sundays. So we will join.
That is just 120 kilometers from Amravati.
Yes. Amravati is my one of the best places. I work at Meghat, so
okay.
I work at Hathru, sir, Semado Hathru, for 1 year.
Okay. You will be going through Paratwada only.
Yes. Almost every time I go through Paratwada, and one of my friend stay there, Dr. Divekar, Abhijit.
Okay.
He's my close friend, and he's my junior also.
Okay.
Sir, I'm eagerly waiting to organize in July or August for your live workshop at Nanded.
Let's see how our next workshop goes first. I'm at Amravati, because this is just a second workshop. First one was very successful.
I will thinking on joining this session, sir, because I'm practicing this, but not able to do that. So, and place is also good. Amravati is one of my.
Yes, it is at college only, so
yes,
you'll have a nice this thing.
Okay, sir.
So I think no one has any question now.
Yes, sir. No one has any question. We will conclude this. Thank you, sir. On our ISA platform, you came on our ISA Nanded City Branch Silver Jubilee celebration year with Platinum Jubilee celebration year of ISA National, and you join this session. We from ISA Secretary and ISA Nanded members, I'm very much thankful to you. Very much thank you. Thank you, sir.
Thank you very much, everyone.
I'm concluding this session, and stop recording will be stopped.
Okay, thank you very much. Good night.
Thank you, sir. I will share this recording with you, sir, after 2 or 3 days.